Welcome students. Today we are going to discuss about a condition which comes in high risk pregnancy. Yes, before moving to the topic, let's discuss how will you identify the pregnancy at the starting stage or in the home setup itself before consulting a doctor. Yes, possibly it's because of vomiting. So today we are going to discuss how the vomiting in pregnancy and how it's in a high risk condition. So vomiting in pregnancy, and moving to the topic, before we can see what are the objectives of the class. So before ending this class, you will be able to identify what is a simple vomiting and what is a hyperemesis gravidarum, and what are the definition of hyperemesis gravidarum, its causes, clinical features, complication as well as management of this condition. So the types of vomiting in pregnancy, it is mainly, as we said in the introduction, there are two types, simple vomiting as well as hyperemesis gravidarum. And what is simple vomiting? So simple vomiting, that is one of the earliest sign of pregnancy, and it is mostly commonly seen in all pregnant women. Approximately 50% of the women will manifest simple vomiting in pregnancy, and the amount of the vomiting also will be small and clear without any bile stain, and it doesn't produce any impairment for the health. And how we can manage this condition? So assurance is one of the important thing. We have to educate or make the woman understand that vomiting is part of pregnancy in the early weeks, and taking of any dry toast biscuits and avoidance of fatty spicy foods and a small doses of antiemetics all can relieve this vomiting in pregnancy. And patient is also advised to take plenty of fluids. And there are a lot of home remedies for simple vomiting, like lemon candies, peppermint candies, and hydration, lime sherbet. Avoid cooking in order to avoid the smell, then ginger tea, and avoiding chips and fries, keeping snacks when you sleep. All these home remedies can make the simple vomiting relief to an extent. So next we are moving to the high risk condition, that is hyperemesis gravidarum. So hyperemesis gravidarum, what is the difference between simple vomiting and hyperemesis gravidarum, or morning sickness and hyperemesis? So that is when the vomiting in the pregnancy will become severe and it incapacitate day-to-day activities, that is called as hyperemesis gravidarum. It is a severe type of vomiting and which has deleterious effect on the health of the mother or make her to incapacitate her day-to-day activities. So when it disturbs the daily routine, that can be termed as hyperemesis gravidarum. And next we can see the incidence of hyperemesis gravidarum. So markedly in this present decades, there is a fall in the incidence rate of hyperemesis gravidarum. Why there is a fall in the incidence rate of hyperemesis gravidarum? So the underlying factors are reduction in the number of unplanned pregnancies, then early visit to the antenatal clinics, and potent antiemetics and antihistaminic drugs. All these are the reasons for reduction in the rate of hyperemesis gravidarum or incidence of hyperemesis gravidarum, and approximately we can see 1 in 1000 pregnancies. So next we can discuss what are the etiologies. So exact etiology is unknown for the high risk hyperemesis gravidarum, but there are a lot of risk factors and possible theories related to this hyperemesis gravidarum. The first one is that it is limited to the first trimester itself. Most of the women will have the pregnancy vomiting, related vomiting in the first 3 months of pregnancy, that is the first trimester, and in few cases it may extend to second trimester also. Then it is more common in first pregnancy. It was considered as maybe because of the exposure to the hormones, pregnancy hormones like HCG, HPL, all those are considered as a fact for it is occurring in first pregnancy, and it got a familial history also. That is, if there is a history in the maternal side, in the mothers or mother sisters or aunt sisters, like if there is a history, that may also can be a risk factor for hyperemesis in pregnancy, and it is more predominant in conditions like high dietary-form mole and multiple pregnancy. So in those cases there will be more amount of human chorionic gonadotropin hormone, HCG hormone, that may be the reason for increased chance of vomiting in hyperemesis in multiple pregnancy and high dietary-form mole. Then it is more common in unplanned pregnancies. Then next we can see the possible theories for hyperemesis gravidarum. The first one is hormonal theory. What the hormonal theory says, that is the production of HCG hormone, and the increased amount of HCG in the body may cause increased vomiting or results in hyperemesis. And the second one is psychogenic, that is the prolonged thinking or thought of repeated vomiting or the vomiting sensations or related to the emotional status or the psychological factors may causes excessive vomiting. Then third one is dietary deficiency. Dietary deficiency, what are the dietary factors which leads to hyperemesis? That are vitamin B6, vitamin B1 deficiency and protein deficiency. These are the three major factors, that is vitamin B1, B6 and protein deficiency may lead to dietary deficiency hyperemesis. And next one is allergic or immunological basis. Those who have a history of allergy or immunological history, resistant history, or that related to, or due to some modifications came in the pregnancy, immunological modifications in pregnancy also leads to hyperemesis. Then the last one is decreased gastric motility is also found to be one of the cause for hyperemesis gravidarum. So these are the theories. So it's common in first pregnancy and it is common in the first trimester that we have discussed, and it got a familial history and it is more relevant in high risk conditions like hereditary mole multiple pregnancy, and it is more common in unplanned pregnancy. And these are the possible theories: hormonal theory, psychogenic theory, dietary deficiency theory, allergic or immunological base and decreased gastric motility. Next we can see what is the changes occur in this hyperemesis. So when the woman starts vomiting in the pregnancy, it may lead to carbohydrate starvation. She may withdraw foods and fluids. So that will lead to carbohydrate starvation. And what will happen when this carbohydrate starvation occurs in the body? That may further results in the breakdown of fats. Depletion of glycogen will lead to breakdown of fat. So when this fats again undergo breakdown, it may leads to ketoacidosis. So the ketone bodies can be appear in the circulating body and in the breath it can present. So this presence of this ketone bodies may result in excessive vomiting. Say a simple vomiting like this with the formation of ketone bodies can lead to further vomiting. That is it may result in excessive vomiting and that may result in hyperemesis gravidarum. Next we can see what are the pathological changes occurs with this hyperemesis gravidarum. So in the certain systems it can results as pathological changes like in the liver, kidney, heart, brain and metabolic system, circulatory system, biochemical changes all can result because of this hyperemesis gravidarum. So we can see one by one. First one is liver. What will happen in the liver? So there will be centrilobular fatty infiltration can occur. So the changes in the liver may result to fatty changes. Then next is kidney. Here also what will happen? The fatty changes in the cells of the first convoluted tubules may occur, it may leads to acidosis. Then the next one is heart. What will happen in the heart? There may be chances of subendocardial hemorrhage may result because of the repeated vomiting episodes. And the next one is brain. Here also there may be small hemorrhages can occur due to in the hypothalamic region and which may be a clinical feature of Wernicke's encephalopathy. It is one of the complication of hyperemesis gravidarum or the increased vomiting. Then the next one is the lesion may be because of the vitamin B1 deficiency. Then the next is metabolic changes. What are the metabolic changes can occur with the hyperemesis gravidarum? That is inadequate intake of foods results in glycogen depletion that we already discussed in the pathophysiology, and this may result in decreased energy supply to the maternal body, mother's body. And due to this low carbohydrate level, there may be accumulation of ketone bodies in the blood. And the acetone is ultimately excreted through the kidney and through the breath. So acetone breath and presence of acetone in the urine excretion we can see. Then water and electrolyte imbalance also may result. Decreased in the biochemical changes will also result. So biochemical factors like blood urea, uric acid, hypoglycemia, hypoproteinemia, hypovitaminosis, and in rare cases hyperbilirubinemia also can result because of the excessive vomiting and loss of fluid and changes. And the sodium, potassium and chloride levels also may decreases because of the increased water loss and vomiting may results. Then circulatory changes. So because of the excessive fluid loss, the concentration, hemoconcentration of RBC, hemoglobin and hematocrit values may increase and the fluids will be losing, and compared to the percentage, the amount of hemoglobin RBC won't be losing. So, the hemo concentration can be increased. Then there is a slight increase in the white cell count with increase in eosinophils. So, there is concomitant reduction of extracellular fluid also may result because of this excessive vomiting. So, these are the pathological changes. The changes occur in the liver, kidney, heart, brain, then metabolic changes, biochemical changes and circulatory changes. Next we can see what are the clinical features. So, there are earlier clinical features and late clinical features can occur. So, what may be the early clinical feature? That is vomiting throughout the day. So, in case of a simple vomiting, what we have seen, the vomiting will be confined to the morning period. Only for few hours after wake up, only the vomiting will be there. So, in case of hyperemesis gravidarum, the vomiting will be present throughout the pregnancy. So, throughout the day the vomiting will be present and which may disturb her daily activities. But there are no symptoms of dehydration and starvation will not be there. So, in the late pregnancy or in the later stages of hyperemesis, what will happen? The vomiting may increases, but the increase in frequency and retching. Retching means the sensation or the act of vomiting. When she get a new smell or a new exposure to new smell, new food or unwanted food like that, she have a sensation to vomit. So, retching also will be there. Then the urine quantity will be diminished because of oliguria, excessive loss. Then epigastric pain and constipation also occurs due to this fluid loss. And the signs are, so we have already discussed the features of dehydration and ketoacidosis will be there. So, what are the features of ketoacidosis? That is like keto, dry coated tongue, sunken eyes, acetone smell and breath, tachycardia, hypertension, rise in temperature may be noted. And in later stages, jaundice also may be occurs. So, these are the clinical features of hyperemesis gravidarum. In the early stage, there will be only vomiting throughout the day, and in the later stages, there may be signs of dehydration and starvation will be there. Next, we can see what are the diagnostic measures. How we can diagnose the condition hyperemesis gravidarum. So, there will be first sign as there will be vomiting throughout the day. The woman will have throughout the day the vomiting, and after that on physical examination we can observe the signs of dehydration and starvation, diminished urine output, all the clinical features will be evident. And along with that we can go for the examination of urine examination, ophthalmoscopic examination, and the further biochemical and laboratory values can be assessed. So, that is the pregnancy to be confirmed first. We have to see that whether the hyperemesis results because of the pregnancy, and thereafter the associated causes of vomiting to be excluded. Then ultrasonography is to be done to rule out hydatidiform mole and multiple pregnancy. Then the investigations is, the first step is urine analysis, that is the quantity and the color, specific gravity and presence of acetone, occasional presence of protein and other bile pigments has to be evaluated. And after that we have to go for a biochemical and circulatory changes. Serum electrolyte balance we have to assess, check for sodium, potassium and chloride. Then the next step is ophthalmoscopic examination, because there may be chances of retinal detachment or there may be hemorrhages in the retina. So, the ophthalmoscopic examination also to be performed. Then ECG, because of the electrolyte imbalance there may be alterations in the ECG can occur. So, that is why we have to go for a ECG checkup also. And next is we are going to discuss what are the complications. So, till now we have discussed about what is hyperemesis gravidarum, what is the definition, what are the etiologies, possible theory for hyperemesis gravidarum and the clinical features of hyperemesis gravidarum, diagnosis of hyperemesis gravidarum. Next we are going to see what are the complications of hyperemesis gravidarum. So, the first two complications are neurological complications. So, in the neurological complication there may be chances of Wernicke's encephalopathy, pontine myelinolytis, peripheral neuritis and Korsakoff's psychosis. So, Wernicke's encephalopathy, that is a usual neurological condition which may result because of the thiamine deficiency. So, this thiamine deficiency may lead to Wernicke's encephalopathy, and like that it may leads to the further nutritional alterations and vomiting in pregnancy. And pontine myelinolytis, that is a neurological condition where there will be damage to the nerve cells and which may result in excessive vomiting. And peripheral neuritis, that's also a condition where there be damage to the nerve damage, and that also manifested with excessive vomiting. So, the repeated strains and repeated stress may cause the small hemorrhages in the brain, and further excessive this vomiting and repeated hemorrhages may result in the nerve damage. And Korsakoff psychosis, which is a neurological impairment condition, results with the complication of Wernicke's encephalopathy. When the Wernicke's encephalopathy is gone as untreated, which results in Korsakoff's psychosis. So, these are the neurological complications. And other than this, what are the complications can occur with hyperemesis? That is stress ulcers in the stomach because of the repeated exotic effort to vomit. The woman may have a stress ulcers in the stomach. Then esophageal tear. So, repeated amount of vomiting will leads to the bleeding and membranous tear, that is called as Mallory-Weiss syndrome. Then next is jaundice. So, we have seen that the ultimate changes, repeated hyperemesis gravidarum, if goes as untreated, that may result in jaundice. And convulsions also can occur. The small hemorrhages in the brain, pathological changes of the brain may lead to convulsions and coma stage. And thus renal failure also may be manifested because of the pathological changes to the kidney, repeated fatty lobular changes in the kidney and acetone depletion and alterations in the biochemical factors like sodium, chloride, potassium, all that leads to final stage renal failure. So, these are the expected complications of a long term hyperemesis if goes untreated, that is neurological complications, stress ulcers in stomach, esophageal tear, jaundice, convulsions, coma and renal failure. So, after this complication, we are moving to the management step. So, before always it is prevention is better than cure. So, better to have a preventive management. How we can prevent this condition? That is, the only prevention is to be part of effective management to correct simple vomiting in pregnancy. So, make it as a wanted pregnancy and avoid maximum number of unplanned pregnancies, and educating the mother regarding the early signs of pregnancy may be the step to prevent this hyperemesis. Next, we can move on to management. So, what may be our principles in the management of hyperemesis gravidarum? First principle is to control vomiting. Then second one is to correct the fluid and electrolyte balance. Correct imbalance, maintain a balance between fluids and electrolyte. Then the third one is to correct the metabolic disturbances. Next one is to prevent the serious complications of severe vomiting and cases of pregnancy. So, these are the steps to manage. And next we have to go for a hospitalization. So, in case of hyperemesis gravidarum, we have to mainly admit the mother to the antenatal ward because it may lead to the complications like neurological complication or stress ulcers, esophageal fever, and in the final stage it may lead to jaundice and renal failure. So, hospitalization is one of the concern in hyperemesis gravidarum. And after hospitalization, what we have to go for? That is fluid management. How we can manage the fluid? That is, after cessation of the vomiting, we will stop with the oral fluids and for 24 hours. So, that should be the first step of management. Oral feeding is withheld at least for 24 hours after the cessation of vomiting. And how we can manage the wound during this period? So, that is through the IV fluids administration. And how we have to go for a IV fluid administration? We have to identify what is the amount of fluid loss occurred from the mother. So, that is the total amount of fluid has to be replaced to be identified. In case if we are administering we are estimated 3 liters of fluid to be replaced. In that case, how will we identify? So, the 3 liter, in that the 50%. So, the 50% of 3 liters, 1.5 liters. 1.5 liters should be a 5% dextrose, and the remaining 1.5 liters should be Ringer lactate solution. So, that is the method for replacement. In case of a 3 liter to be replaced, 50% is 5% dextrose and the remaining 50% is Ringer lactate solution. And there should be extra amount to be also replaced. How we can calculate? That is, the extra amount is equal to 5% dextrose we have to replace, and the amount should be equal to the amount of vomiting and urine she passed in a 24 hour. So, that also to be replaced. Identify the urine amount and vomiters she had vomited during a 24-hour, and that has to be also replaced along with this 3 liters with 5% dextrose. So, hope it's clear, that is the amount of fluid to be replaced to be identified, and in that the 50% should be 5% dextrose and 50% another 50% is ringer lactate solution, and there should be an extra amount also to be replaced, that is the amount should be equal to the amount of fluid loss from the mother's body in a 24-hour, and that should be replaced with 5% dextrose. Okay. Next is why we are administering this in a regime, that is this regime will helps to prevent dehydration, ketoacidosis, water and electrolyte imbalance. So, that is the necessity. Then serum electrolyte also to be estimated and to be corrected as early as possible. Then next is after fluid replacement we have to go for a medication, drugs to be administered. So, how we can administer these drugs? The antiemetics what we are preferring is promethazine, Finnergan 25 mg or chlorpromazine, that is Stemtil 5 mg, trifluoropromazine Squinal, that is 10 mg, may be administered twice or thrice daily intramuscularly. Then vitamin B6 or doxylamine also safe and effective during pregnancy. Then metoclopramide stimulate gastric motility without stimulating the secretion. It is also found to be useful, because one of the theory for hyperemesis is that is decreased gastric motility. So, these are the preferred drug of choice antiemetic, that is Finnergan, promethazine 25 mg or prochlorperazine, that is 5 mg or trifluoropromazine, that is 10 mg. These are the 3 drug of choice which can be given twice or thrice daily. Then vitamin B6 and doxylamine also safe in pregnancy, and metoclopramide also can be given to increase gastric motility. Then the next one is hydrocortisone, 100 mg IV also can be given to prevent hypotension. So, as a part of dehydration and starvation, the woman may go for a hypotension. Then nutritional support, that is with vitamin B1, B6, vitamin C and vitamin 12 can be replaced, nutritional deficiency to be corrected. These are the management for hyperemesis gravidarum. So, the first step is hospitalization, second step is fluid management and drug management. And what are the nursing aspects? How we can manage the person in a hyperemesis stage. So, the first step is sympathetic and firm handling of the patient. The woman has to be reassured. She may be tired, physically tired, and emotionally she will be unstable because of the repeated episodes of vomiting, and she may not take even a single food or snacks because of this vomiting. So, that has to be emotional support and reassurance has to be given. Then the next one is social and psychological support also can be extended. Hyperemesis progress chart we can maintain as a nurse's responsibility. So, the chart can be shown to the patient, and we can also assess what is the amount of fluid loss in the repeated days and how she is progressing. And the intake and main intake output chart, daily record of vital signs and urine acetone, protein, bile and biochemistry values, ECG, all these parameters to be assessed and periodical assessment and monitoring to be done. And the clinical features of improvement we have to assess. What may be the signs of clinical improvement? Clinical features, that is subsidence of vomiting. Throughout the day she may be vomiting in the previous day. So, in the progressive days she may reduces the number of vomiting and feeling of hunger. So, the starvation or dehydration level, when it reduces, she feels hunger. Then better look. So, in the clinical features we have already seen that she may be fatigue, sunken eyes, Asst smell and breath, all that clinical features will be there. So, all that will starts to become better. And disappearance of acetone from the breath and urine, normal pulse and BP and normal urine output also she may regains. Then diet. So, before the intravenous fluid is vomited, the foods are given orally. When the IV fluids we are stopping after a 24 hours of replacement, we will go for a oral foods. And at the first day we will start with dry carbohydrate foods like biscuit, bread and toast are usually preferred, because which the foods which would not stimulate further vomiting has to be administered first. So, dry carbohydrate items are preferred in the first stage. Then after that, small and frequent foods can be recommended, and gradually full diet is to be restored. And fluid replacement also is one of the concern. Ask her to take adequate amount of oral fluids. So, that is all about hyperemesis gravidarum, and that is the final stage of hyperemesis gravidarum, when the pregnancy is not possible to continue with the pregnancy, continue with the vomiting, and along with the pregnancy what will go for termination of pregnancy is also rarely indicated in few cases. And that is hyperemesis gravidarum always can be treated with mainly reassurance and support from the stage of simple vomiting. It should not be progressed to a stage of hyperemesis gravidarum. So, today we have discussed about a condition that comes under the high risk pregnancy, that is hyperemesis gravidarum.